Well, thank you for the kind introduction. I'm going to be, you can see this the topic I'm going to be covering today. These are my disclosures. I am a member of the NIH guidelines panel, but the opinions I represent today are my own. So what is highly treatment experienced? If you ask enough providers, you get many answers. However, there's really no unified definition in the field of what a heavily treatment experienced patient is. But there are some themes: multiple prior regimens and multi-drug resistant HIV. And clinically, I think if you think about, can you construct a regimen that consists of at least two and preferably three new drugs for a patient? And if you can't, they're definitely heavily treatment experienced patient. So what is multi-class resistance? Well, we currently have 8 drug classes to treat people with HIV, which is quite amazing, in around 30 agents. But we only have resistance testing for about 5 classes listed there, and CA stands for CCR5 antagonist, meaning really just checking to see if the tropism for the virus. But there is limited testing availability for 3 of the newer classes: attachment inhibitors, post-attachment inhibitors, and fusion inhibitors, mainly available in clinical trials. And why that's important is when you define multi-class resistance, you'll see in the literature, they'll say greater than 1 class, greater than 2 class, greater than 3 class, and the like. But really, we can only go up to about 5 classes currently. And I do want to point out that it gets very complicated when you talk about the number of class resistances. If for you math majors in the room, anybody want to guess how many different 2-class combinations you can make from 8 classes? Well, the number is 28 possible combinations. And how about 3-class combinations? You can see that the number gets even larger. And that's the formula there for those of you that want to see what the other combinations would require. I think that's important because I just wanted to point out that you can see that many different combinations are possible. And in the literature, if you use a simple definition of greater than 1 class resistance, it's very simple, but it's not very informative clinically. Because when you think about all 28 possible 2-class resistances, are they really the same? Is NNRTI plus NRTI the same as a 2-class resistance for NRTI plus an integrase inhibitor? And I propose that, to you that clinically, one type of 2-class resistance is not weighted the same for every patient, as it depends upon the mutations in the patient's virus, ARV tolerability, prior treatment history, comorbidities, and drug-drug interactions. So it can get very complicated. And I wanted to set that up because now I'm going to run through a little bit of how common multi-class resistance is. Now, this was a very large study from the US, from a reference laboratory, and it showed that 2-class and 3-class resistance actually had declined over the last 10 or 11 years, down to about 17%, but still pretty significant in the samples that were submitted to this large reference laboratory. And integrase resistance containing 2-class resistance was about 10%, but in 2017 it was 9%. So it does show that it is also declining. And recently in the Euroresist that was presented at CROI this year, they showed that 4-class resistance also was around 2.5%. And it also had been declining. This is all good news that it's declining, but you can see there is still a small minority of patients that actually have significant multi-class resistance. And this was an interesting study evaluating pre-existing resistance in virally suppressed patients that were switched to a new integrase regimen. And when you combine both the historical genotype and proviral DNA genotyping, you can see that many patients harbor drug-resistant variants within the proviral DNA genotyping. And this was a very large study also from the US, another reference laboratory that analyzed over 80,000 samples over the last decade or so, around 6 years. And you can see overall it has declined, and in 2008 the numbers are less than they were in 2012. However, there is a significant population of patients that have 2-class, 3-class, or even 4-class resistance. And just last week in Glasgow, a really interesting report from Italy came out where they looked at 31,000 patients in their multi-cohort study. And multi-drug resistant patients, defined as patients that had 2 or fewer active drugs available, had a higher risk of combined endpoints of AIDS or death. So it does matter if you have multi-class resistance. So I briefly want to cover a couple of key points on how you treat people with highly treatment experienced patients. So if a person's failing their regimen, the first thing you should do is assess for adherence, drug-drug interactions, drug-food interactions, ARV intolerance, and patient comorbidities that might be contributing to the virologic failure. You should assess all the viral load and CD4 cell trends over time. And importantly, you should review all ART history, prior and current drug resistance results, and consider a tropism test. And you should use all that information to construct a cumulative genotype and use that information to decide what are the best drugs to choose for the patient's new regimen. And the new regimen should include 2 and preferably 3 fully active agents. And get expert advice if needed. So why do we say 2 or 3 new drugs? Well, this is an old study, but it was very important. This was the TRIO trial. It was published back in 2009. But it showed that in heavily treatment experienced patients, if they were giving 3 new drugs, and in this case, raltegravir, etravirine, and boosted darunavir, they had viral load suppression rates similar to treatment naive patients. And also in the Viking 3 study, where it was looking at dolutegravir in patients that had integrase resistance to the earlier integrase inhibitors, raltegravir and elvitegravir, it showed that patients actually did very well if they were given a new integrase inhibitor and an optimized backbone therapy. And what was important about this study is that it was a unique study design that had a short functional monotherapy phase where the new drug is given for around 7 or 8 days. And then the patient is given an optimized backbone therapy on top of that. And you really evaluate, does this new drug have efficacy just during those 8 days? And it's basically a functional monotherapy phase. And I wanted to point that out because the next couple of slides I'm going to show you of new trials also use that study design. But in general, when we treat patients, we don't add a single agent to a failing regimen. It's not recommended because if you leave a person on that, this could risk the development of resistance to all the drugs in the regimen. So in the clinical trials, they only do it for a short monotherapy phase of only 7 or 8 days, and then they rescue it with an optimized backbone therapy. When you choose other drugs, you can add some drugs that have partial activity against HIV, and they can be retained in the regimen. Many of these are some of the NRTIs, PIs, and some of the second generation integrase inhibitors still maintain some efficacy. But for some heavily treatment experienced patients with extensive resistance, maximal virologic suppression may not be possible. And the goal for those patients is to continue the ART and design it so it minimizes toxicity, preserves CD4 cell count, and delays clinical progression. Stopping ART is not recommended as it increases the risk of disease progression. And importantly, when it's not possible to construct a suppressive regimen for a patient with multi-drug resistant HIV, considering a clinical trial of investigative agents. So in the past decade or so, there's been 10 phase 3 trials evaluating the safety and efficacy of persons with multi-drug resistant HIV. For raltegravir, moraviroc, the CCR5 antagonist, etravirine, NNRTI, dolutegravir, and Evolusimab, abbreviated IBA, which is an anti-CD4 cell antibody. And recently, the BRIGHT study evaluating Fosten Severe, which is a first-in-class attachment inhibitor. Now, there's other agents with unique mechanism of actions in early phase trials currently, and you'll see about them in different clinical trial situations. There's nucleoside reverse transcriptase translocation inhibitor. There's a new humanized monoclonal CCR5 antagonist. There's capsid inhibitor and broadly neutralizing antibodies. And I don't have time to go through all those today because many of them are still in phase 1 and some are in early phase 2 and some are in currently phase 2, 3. But I wanted to focus on some of the newer agents, Evolusimab and Fosten Severe, because they are now available to many of you because they have been FDA approved and are undergoing European approval currently. So first is Evolusimab. This is a post-attachment inhibitor. This study was published in the New England Journal by my colleague Brenda Imu in the picture there. Brenda's a professor here at Yale with me. Evolusimab is a non-immunosuppressive monoclonal antibody that binds to the CD4 cell receptor and it prevents HIV particles from entering the lymphocyte. And when you look at the licensing study, 43% of the patients had a non-detectable viral load when Evolusimab was given with an optimized backbone therapy at week 25. 50% had a viral load less than 200. Now, this drug is given by IV infusion every 2 weeks after a loading dose, and most patients tolerate this drug very well. Now, this was a very small study. It only had roughly around 40 patients. And so the number of patients that have been exposed to this drug in clinical trials is limited. However, the safety profile looks very good. You can develop a hypersensitivity reaction to this, and some patients develop iris, which is not unsurprising given the advanced state of many of these patients prior to receiving the drug. But the most common side effects, at least out to week 48, is diarrhea, dizziness, nausea, and rash. But overall, it's actually a very well tolerated drug, even though it's an IV infusion every 2 weeks. So I had the pleasure of publishing this with my colleagues in New England Journal earlier this year. This is Fosten Severe, and this is a first-in-class drug that it actually is the prodrug for Temsivir. And this drug binds directly to HIV-1 GP120, and it prevents initial viral attachment and entry into CD4 cell positive T cells. And for those of you that have access to the New England Journal, there was a very nice video of the mechanism of action of this drug. So I encourage you to look this up, and actually, when you have time, you can see how this drug actually works. It's a very unique mechanism of action. So this study was a larger study for heavily treatment experienced patients. It's an ongoing multi-center with 2 cohorts. It was done in 108 centers across 22 countries. And it had a unique trial design. Number one, the randomized cohort were patients that still had 1 or 2 fully active agents available, and they were randomized either to receive Fosten Severe or placebo for 8 days. And then afterwards, all patients were given an optimized backbone therapy with Fosten Severe on board. However, if a patient had no available active agents left in the regimen, they were allowed to basically have an expanded access compassionate use-like protocol where all patients receive Fosten Severe with an optimized backbone therapy right from the start. And I'll present both of these limbs moving forward. And this is just the enrollment and outcomes out to week 48 in this population. But I wanted to point out the characteristics of this population at baseline. They were very advanced. In the randomized cohort, the median CD4 cell count was 99 cells. And in the non-randomized cohort, the median CD4 cell count was 41. And 86% of the patients reported a history of AIDS. So these were very advanced patients. And most had extensively exhausted their prior ARV regimens. And I'll blow that up for you so you can see it a little bit easier here. So you can see this table actually shows the exhausted ARVs in the population, both for the randomized and non-randomized cohort. And you can see there's 6 drug classes here. And for the non-randomized cohort, you can see the vast majority had exhausted all available agents prior to enrolling in this study. If you couldn't tolerate one of the regimens, that also was considered a reason not to use that. And so that's why it's not 100% in all those patients. So the primary endpoint of the study was the viral load change by day 8. And that was found to be highly significant, with Fosten Severe having a viral load drop of about 0.8 logs by day 8 versus placebo. And the figures here on the top panel were the observed data of patients that stayed on study and received Fosten Severe. And you can see that viral load suppression rates were 62% at less than 40 copies out to 48 weeks, and less than 200 copies, 84% of patients had a non-detectable viral load in the randomized cohort. So these patients had one or two fully active agents combined with Fosten Severe, and you can see they had a very robust response. In the non-randomized cohort, these were patients that had no other available agents, although 15 patients did receive Evolusimab in their optimized backbone therapy, because the study allowed patients in the non-randomized cohort to co-enroll in other additional studies. And you can see that roughly 50% of the patients had a non-detectable viral load out to 1 year, which is very nice to see with this regimen. And they had very good CD4 cell responses. And I'm going to show you some of the CD4 cell responses out a little later, out to week 96. Overall, the drug was extremely well tolerated. And the main side effects were nausea, diarrhea, and headache. And these were very consistent with the phase 2 study. And most patients were low grade and were self-limited. And very few patients discontinued study due to that. But this is the intent to treat data. This is the most rigorous snapshot analysis of patients that received Fosten Severe. On the left-hand panel is the randomized cohort. And you can see that 60% of the patients had a non-detectable viral load out to almost to week 96. And there's a very interesting and not seen in other prior phase 3 trials for heavily treatment experienced patients continued to have a rise in the proportion that had non-detectable viral loads, which is a very unique finding. And you can see of the patients in the non-randomized cohort, it's a very stable patients with viral load suppression rates maintained out to 96 weeks. So this is the week 96 data that will be coming out in press soon. And you can see that this is observed data, and you can see again this trend where patients are continuing to have non-detectable viral loads in the patients that have Fosten Severe with an optimized backbone therapy, and also in the non-randomized cohort. And interestingly, the CD4 cell count responses are, on average, the mean CD4 cell count rise in the randomized cohort regimen was up to 200 by week 96 and over 100 in the non-randomized cohort. And patients that had very low CD4 cell counts at baseline, you can see had a mean rise in CD4 cell counts if they remained on study in the observed cohort of up to 240 cells, which is quite robust. So in general, heavily treatment experienced patients who receive at least 3 active drugs experience a better and sustained virologic response than those that receive fewer agents. And a fully active agent is a drug that is expected to have uncompromised activity based on the ARV history and also the past and current resistance results. And active drugs may be newer members of the existing class that still maintain some activity, especially to the versus viruses that are resistant to some of the older drugs. And so some of the newer drugs, like etravirine, darunavir, dolutegravir, doravirine, and bictegravir, may have some activity, although there's limited data with doravirine and bictegravir in this setting. We need to still see the clinical trial data from those compounds. But importantly, a drug with a new mechanism of action that is different than previously used ARVs can be critical components of a new regimen, such as fusion inhibitors like T20, CCR5 antagonists like Maraviroc, post-attachment inhibitor Evolusimab, and also the new attachment inhibitor Fosten Severe. And if you can't find enough agents to construct at least 2 and preferably 3 fully active agents, consider a clinical trial with a novel mechanism of action. So I know that was a very quick evaluation of some of the newer agents, and I'm looking forward to our discussion in the Q&A session that's coming. So thank you again for attending, and talk to you soon.